I want you to understand what symptoms mean and what they should tell you about your health and about your body. Learn how to read your symptoms. When you don't understand symptoms versus cause, symptoms versus problem, okay, then the headaches themselves become the problem. Say yes if you get that. So it all becomes, let's make the headache go away, all right? So, of course, the question is what can I do, what can I take to just make the symptom go away? Most people come in and they say, Doc, I've got this going on. What do you think, should I take this? And I'm like, I don't know. Is your objective that you want to live a longer, stronger, healthier life? You want to reduce your chance of having heart disease, heart attack, dying of a heart attack? You want to increase longevity? Is that what you're trying? The problem is very often drugs will work and they will quiet the symptom while you get sicker. So we need a better way. There's basically two major types of inflammation. There's acute inflammation, which is the swelling that most of us understand. You sprain your ankle, there's soft tissue damage, there's basically a chemical reaction that happens in the body, and you swell, okay? That is innately appropriate. Now the second type is what most people don't understand, and that is inflammation on a cellular level. It's an insidious, low-grade, chronic inflammation, silent inflammation. Chronic low-grade inflammation looks like this. Read this list now. Heart disease, high cholesterol, high blood pressure, strokes, mood disorders, depression, anxiety, brain degeneration, Alzheimer's, senility, obesity, diabetes, cancer, there's the trail, right? Joint pain, swelling, arthritis, atopic disorders, allergies, asthma, eczema, and acne, poor recovery and healing, and immune responses. Sound like anybody you know? I won't make you raise your hand or stand up and stomp your feet if it sounds like you. There's a life of probability and there's a life of possibility. The life of probability is the one that if you just keep doing what you've been doing, you'll probably experience. And then there's a distinctly different experience out there, and that's a life of possibility. And that possibility, that life of possibility, is not the default mode. It's chosen. It's a decision. It doesn't happen passively. It's active. It's something that's chosen. So tonight, I'd like to suggest that we all get to choose. And one of the first steps that you can take in making that choice is making a commitment to living unconditionally.
Tonight, our Body Scenes workshop. It's the 5th one, I believe, in the series. We've got the whole year. Next month's Body Signals workshop is going to be on the upper extremities. So the shoulders, the elbows, the wrists. And that's going to be on a Tuesday night, July the 2nd. So definitely make sure you get here right before your 4th of July festivities. Right. So that'll be at 6:45, the same location. Also this month, middle of the month is Father's Day. So in honor of Father's Day, we are celebrating our dads in the clinic by giving away a huge barbecue grill. and as well as some grass-finished steaks, and then a Franson Family Chiropractic wellness package, which includes some beach stuff, some fish oil, some bonfire bucks, so you can buy things in the practice, more supplements, and that's going to be the entire month, and we're going to announce the winner there on Ohana Day, which is our annual appreciation day of all the great patients we see in the practice. It's a great time for all the families to come out and spend time together, be in community with each other. We're going to do that this year in Beverly Farms with a softball game, and it's going to be Dr. Camilla's team. If you haven't met her, Dr. Franson's better half.
Better 70s.
And versus Dr. Franson's team. And so we'll have a softball competition at the end of June, and you'll get information about that here in the practice, and we're super excited about being able to spend time with people outside of the practice. Other than that, those are the big events going on. I just wanted to take a moment to introduce Dr. Franson to all of you. I once sat in those seats as a patient, something like 13 years ago. So I was the guy in the back taking notes, writing everything down, and then going home and not reading it again, because the next time I came in, Dr. Franson would give me just more information to take in. There's so much information, it was changing the way that I looked at my body and my health every single day that I said, the heck with it, I have to go to chiropractic school to learn all this information. So maybe 10 years ago now, my life completely changed. I quit my job after 2 years in this practice. I made a choice. I asked Doc one day, I said, you know, what do you think I should do? I was an environmental engineer. I wasn't really happy with my profession, but I was an athlete. I was working out all the time, and I was in chiropractic care in order to help improve my recovery and my performance. And I said to Doc, what do you think I should do with the rest of my life? And he's like, if you're asking me, then you should be a chiropractor. And 2 weeks later, I quit my job and moved to California, and went to chiropractic school out there, and established, after that, I practiced in Australia, but Dr. Franson was the person I was always calling, always emailing, looking for advice. He's become a friend and a mentor, one of the best mentors you could have. As you all know, he's a great coach in life, in health, and in relationships. So I am pleased to present to you Dr. Steven Franson.
Thank you, buddy. Thank you, man. How's everybody doing?
Great.
Yeah, good. I'm Dr. Steven. Welcome to our awesome clinic. Is this a great place or what?
Yes.
Does everybody recognize this face here, or some of you recognize it? So everybody say, hi, Sarah, good to see you. And this is her new husband, Chris.
Hi, Chris.
Say hi, Chris.
Hi.
We love Chris. He's a new member of the family. We're really excited to announce that these guys are going to be actually opening their own CrossFit together, their own gym, CrossFit Box. So we're really, really proud of them. We're really, really excited for them. And you'll hear us promoting them like crazy, because you couldn't imagine a greater place to go to just learn more and more about getting healthier. So you see I'm holding my phone. So this serves two purposes. This reminds me to remind you to shut your phones off. Isn't that nice? It's just going to kill that thing. If you don't know where the power button is, every phone has one. There's a power button where you can actually shut these stupid things off and unplug from the world. So I'm going to give you permission for the next approximately 35 minutes to shut these things off, right? And it also reminds me that I promised you guys that it's my goal that we get across all this information inside of a 30-minute window, which is a big challenge for somebody like me, because I just love to talk, all right? So I'm actually going to set the stopwatch, because I like to challenge myself, and the doctors like to challenge me to see if I can actually get it done, because we've got a lot of material, and as usual, I talk fast, so listen fast, all right? So tonight we are here for our the first of in a series of 2 workshops on adult onset FAS, which is, of course, falling apart syndrome. Anybody getting struck with any falling apart syndrome symptomatology? Yeah, I know you guys. I take care of all of you. All right, so the first one we're going to do tonight is lower extremities. So we're going to talk about hips, knees, and a little bit on ankles and feet as well, okay? The next month we're doing upper extremities. So we're going to do some shoulder, elbow, wrist, hand stuff, okay? So tonight we're going to start here with just an anatomy lesson. So here's my deepest belief, is if human beings understood how awesome this body is, you would just simply take better care of it. Say yes if you believe that. Okay, so God gave you this awesome gift. It's one of the greatest gifts you'll ever get, which is this incredible body that's incredibly smart. Say yes if you believe that.
Yes.
If you don't believe that, think about it. Think about your age. Everybody say your age out loud. Only kidding. All right. I know, you're 84. So 84 years ago, a sperm and an egg bumped into each other, and 17 years later, you're taking the SATs. Now that's a lot of, that's intelligent, right? That's the same intelligence that runs every cell in your body, that runs every tissue, every organ and organ system in your body. How awesome are you, okay? It's also the intelligence that heals your body. So as we work together tonight, we're going to help you understand some of the problems and some of the aches and pains that people are struggling with, some of the symptoms, crises, and some of the degenerative conditions that they've got themselves into. But above all, what I want you to understand is that the body is a self-regulating and a self-healing organism. All right. So most of the problems that we're going to talk about tonight are largely correctable, and I will make the argument that almost all of them are preventable. Say yes if you believe that. Okay, good. All right, so we're in the right room. So let's look at the anatomy of essentially this lower extremity. All right, so this is looking at a person from behind. All right, so you have the lumbar spine, you have the hips and pelvis. Okay, you have these are the legs. This is the femur head, which is your upper leg bone, your femur head into your femur. This is your tibia and fibula at the bottom of the leg here. All right, so looking at a person from behind, these hip bones, these crests, are what most people think of as their hips, right? So when we talk about hip problems, I'm going to unpack that a little bit tonight so you understand that, you know, the application of that term hip is really, really broad in healthcare. All right, so how many people are struggling with hip problems right now? Okay, all right, so it's a super common problem that we see. And there's essentially three types of problems that get sort of lumped together into hip problems. All right, so these are usually lumbosacral issues. These are SI joint problem issues. These are actual femur head issues. Okay, so the actual hip itself. So we're going to unpack that tonight so you have a better appreciation for that. So lumbar spine, this is the sacrum. This is the ilium, so this becomes the sacroiliac joint, SI joint. Not to be confused with the Sports Illustrated joint. So this is sacroiliac joint, okay? And this is the actual hip joint. So if you know anybody who's had a hip replacement, you've been told you've had hip degeneration and maybe a candidate for hip replacement, this is the joint that they're referring to. And this is basically where your leg attaches to your big, strong pelvis, okay? This is considered a closed kinetic chain, all right? So closed kinetic chain versus this upper extremity, which is considered an open kinetic chain. Okay, so the difference between these two is one of them is weight bearing and the other one is not, okay? Unless, of course, you're inverted doing handstand push-ups, okay? Right, Chris? Yes? Then it becomes a closed kinetic chain in all application, okay? So this closed kinetic chain, being weight bearing, has a different set of rules biomechanically that it plays by. Does that make sense to you guys? All right. Mm-hmm. Now, you have, in this closed kinetic chain, you've got that lumbar spine, you've got the SI joint, you've got the hip joint, you've got the knee joint, you've got the ankle, and then the feet, okay? So all of these joints work together to not only keep you upright, okay, and help you ambulate, okay, but they work together for all movement, all stability, all activity, essentially. Make sense? They all work together. Now, typically what we'll see is if somebody has a problem with one of these joints, it creates sort of collateral problems around it. So if you have a hip problem, it creates knee problems and heel problems and feet problems. Make sense? All right. So we're going to unpack that tonight. Of course, if you have a direct trauma to a joint, like you may tweak your knee in skiing and you may have an actual knee problem itself that's considered an acute injury, tonight we're going to focus more on sort of the chronic degenerative issues that people have a tendency to show up here with. Make sense? Okay, good. All right, so in this closed kinetic chain, because all of these pieces and parts work together to give you your gait or your stride, whether you're walking or you're running, they work together and therefore they have a tendency to rely on each other for proper function. And if one part of that chain is dysfunctional, it translates into the other joints. So you end up with all sort of the cluster of problems, right? So very often what you'll see is people end up with a cascade of issues. The closed kinetic chain, very often you'll see low back pain, you'll see SI joint dysfunction, you see hip degeneration, you see arthritic knees, ankle problems, foot pain, bunion, march fractures, etc. And all this issue around distribution of forces gets changed in the physics and the mechanics of this lower extremity change. And this is what we refer to as FAS, or falling apart syndrome. Say yes if that makes sense to you. Yes? Okay. All right. So let's start breaking these down. This one's for Dr. Paul. I love that one. Growing old is not for sissies. All right. So let's talk about this. So here's your anatomy of your pelvis. This is looking at you from behind. I'll use this. So this is a spine. Here's your lumbar spine right here. This is the thoracic spine, this is the cervical spine. The lumbar spine comes down into the sacrum. The sacrum is this big triangular bone at the bottom of your spine that makes up a portion of your pelvis. These are your ilia, okay? This is the right one, this is the left one, right? These are your sit bones, right? These are your ischial tuberosities. These are the things you actually sit down on, right? This is the sacrum, this is the coccyx, right? So people talk about their tailbone, this is actually your tailbone down here, all right? The sacrum is called the sacrum because they used to think it was the sacred bone. They thought that the soul resided in this bone. Isn't that interesting, right? So when we look at this this pelvis, there's a series of 3 joints that we were concerned with. The lumbosacral joint, which is where the 5th lumbar meets the sacrum. That's the L5, 5th lumbar. S1, first sacral tubercle. These are called tubercles. There's 5 tubercles. There's 5 joints that actually fuse together when you're about 15 years old. Like these are joints here. This fuses into one big plate of bone at about 15 years of age, okay, and it forms this sacrum. The 5th lumbar sits on top of the sacrum, and there's a disc right there called the 5th lumbar disc, okay? This is the most commonly subluxated joint at the bottom of the spine. Some of you are saying, yep, I got a 5th lumbar problem, all right? Because you've got this really mobile spine that comes down and sits on this really strong but stable pelvis. So one of the last freely movable segments down here is the 5th lumbar disc. So this ends up being a really common problem for people, all right? This 5th lumbar, when it gets damaged, swells and puts pressure on the nerves that are trying to leave your spine at that level, okay? That problem is called subluxation, which we'll learn more about tonight, okay? Now the other joints, there's 2 SI joints, or sacroiliac joints, okay? So here's your ilium, here's your sacrum. Where they meet, that's the sacroiliac joint. The SI joints go, if you reach back behind you, or reach over to somebody you don't know, and grab them right here, okay, right on either side of the spine, right? Reach back, you can feel those little dimples right above your belt line. Everybody feel that prominence there, that bony prominence? It doesn't matter how big your buttocks are, you can always feel this bony prominence back there. It's a landmark, okay? So you put your fingertips right up on there, right? Those are your SI joints. They go like this when you walk, okay? So the ilium and the sacrum fit together like this, and the surface looks like an ear. They call it an auricular surface, all right? And there's a top portion of the joint and a lower portion of the joint, and it gives you a bit of a figure 8 when you walk, okay? It gives you a figure 8 in your gait. Now the lumbar spinal joints, they like to pump up and down when you walk, okay? And that pumps the discs and moves healthy fluids through the tissue, and that keeps the disc healthy, okay? They don't like to go like this. Your SI joints go like this, all right? Now when you come off of the SI joint, come around to the ilium, you'll see there's a fossa right here, and this is where your actual femur head or your leg fits in. Everybody see that? All right? So this is usually what people refer to as the hip, up in here, okay? But your actual hip is down here, where your femur inserts into this big piece of bone here called your ilia. Everybody see the anatomy there? So those joints here, where your legs fit in, they go like this. So you have this motion, and you have this motion, and you have this motion. And all of those work together to create your gait pattern and your movement patterns. Everybody see that? Now they work as part of a team. Now, if one of those joints gets out of a healthy position or swells and creates dysfunction, the other 2 joints have to do more work. Make sense? If you have 3 people rowing a boat and one of them's not rowing, the other 2 have to work harder. Good? So when these 3 joints are supposed to work together and one of them gets damaged and swells, the other 2 have to jump in and do more work. Make sense? Okay, so what happens is they start to break down. If the stress is transferred into those joints and they start doing a job that they're not designed to do, or they're doing more work or more movement than they're designed to do, they actually start to break down. And that breakdown is known as arthritis, okay, or degenerative joint disease. Now, one problem I want to take a look at is the first of these 3, when the first of these 3 become a problem, is the SI joint problem. Okay, so this is looking at that pelvis straight away from the front. All right. Here are the SI joints. Here's your sacrum. Okay, that's the left SI joint. There's the right SI joint. When this irritation happens, what happens is essentially the SI joint gets jarred out of a healthy position. That creates damage to the soft tissue. The soft tissue will swell, and the joint becomes fixated. Okay. Now that joint, as it swells, will also create nerve irritation. That nerve irritation is the real problem, okay? Because the nerves that exit the spine at this level, they feed not only the muscles of the lower back, but they also feed the bowels and the bladder, the prostate in men, reproductive organs, down the legs and into the feet, okay? So we have a complex issue here. We have a functional disorder where mechanically the pelvis doesn't work properly and we end up with degenerative issues. And that is a bit of a downward spiral. Make sense? And as that degeneration continues, the joint weakens and it creates more inflammation from more tissue damage and we end up with more nerve irritation. Okay? When your body experiences nerve irritation, it changes the information that's going across the nerves to keep those tissues healthy, keep them functioning properly, and keep them healing. Okay? This problem is called subluxation. Everybody say that with me. Subluxation. Okay? So a subluxation occurs when a joint gets jarred out of a healthy position, creates soft tissue damage, inflammation, and nerve irritation. All right? So this is a super common problem that we see. So when this SI joint gets subluxated, what happens is the stress that's usually shared between these three joints in those movement patterns gets distributed. It gets distributed from the SI joints out to the hips and gets distributed up to the disc. So for example, if somebody has a right SI joint problem, that joint doesn't work properly. So instead of the pelvis doing a figure 8 when they walk, this person will have a tendency to waddle in their gait. So the SI joint sticks on that side, so when you watch them from behind, instead of them gating like this, you'll watch them pull and pull and pull from the side. So as you watch them walk from behind, they've got a waddle that they'll pull off to that side. Make sense? All right. And then what happens here is instead of the pelvis doing this, and the fifth lumbar, the lower vertebrae in the spine, gets to do this and pump and keep the disc healthy, as that joint starts pulling with each step, it starts twisting and rotating the joint. So when that happens, what happens is it's essentially, like I said, discs don't like this torsion force, doesn't like that. So it starts to actually grind the joint down, okay, and tear up the fibers that surround what's called the nucleus pulposus, which is the ball bearing inside of the disc that the joint moves around, okay? That creates tissue damage around that disc, and that creates more inflammation and more nerve irritation. So you end up with a secondary subluxation problem, okay, in the fifth lumbar. Super common to see that. So first thing that happens is you subluxate your SI joint through some type of trauma. Either some type of macro trauma, like a fall. You fall down on your butt when you're a kid. You slip on the ice and fall down on your hip, okay? Or from micro traumas, where you have bad habits like crossing your legs, or sleeping in a big twist, okay? Or picking things up on the floor like this, as opposed to facing it and going down and picking it up properly. Make sense? When you subluxate that SI joint, it starts that cascade of issues that sometimes will manifest downstream as a sciatic problem because now the fifth lumbar becomes a secondary issue. Now what happens also is that stress will go downward, and instead of being part of this motion through the hips, the stress will be distributed to the actual hips themselves, to where the femurs insert into the ilia. Okay? So what happens is those joints start working overtime, and they go through larger ranges of motion, and they have more aberrant stress upon them than they're designed to have. And that's a super, super strong joint. It's the strongest joint in the body. And what you end up seeing is that joint breaks down and tears up, and that's where you end up with degeneration in the hips. So the SI joint gets subluxated. Over time, the hip itself wears down, and people end up with hip replacements. Okay, we'll talk a little bit more about this. So subluxation is the joint gets misaligned. We're talking specifically about the SI joint. You end up with soft tissue damage and inflammation. The inflammation creates nerve irritation because it crowds the tissues as it's trying to leave the sacrum. You get muscle spasms. Why do we get muscle spasms? Is your body smart or stupid?
Smart.
Smart or stupid, guys?
Smart.
Yes, right. I'm in the right room, right? So smart, right? Very smart. So when there's tissue damage from joint instability and soft tissue damage, that inflammation sets off an alarm to the body because it hits that nerve, and that nerve says, whoa, that nerve pressure is incredible. So the muscles will go from their primary job from being joint movers to becoming joint stabilizers. So they go from being pulleys, which move joints, to becoming straps, which holds joints together. Does that make sense? So when you injure yourself, your very smart body senses that nerve irritation then from that inflammation, and it'll actually tighten up the intrinsic muscles around a joint. So instead of the muscles being primary joint movers, they become secondary joint stabilizers and strap you down. That's where that muscle tightness and spasticity comes from. And for a lot of people, they come in here and they're like, oh, it's a muscle problem, doc. I think I got this muscle thing going on. And I always say, you're right, Judge. There is a muscle issue involved here. Your very smart body is battening down the hatches and protecting that SI joint so you don't do more damage to the disc around there. How smart are you? Okay? Now, knowing how smart you are and how that's a smart reflex by the body to protect you, does it make any sense that the answer would be pop pills to relax the muscle and then pop more pills to block the pain signals that let you know you're tearing up tissue and causing more damage? Do you understand that? So that's insanity to think that way. So like, okay, so I'm just going to pop pills and relax the muscles that are guarding the injury, and then I'm going to pop more pills to take away the pain so I don't even know what ranges of motion are creating more tissue damage. And that's the people that feel better as they're getting worse. You know people like that? Mike, you know lots of people like that, right? Popping pills so they feel better while they're getting worse. Then it's a really scary, sad, tragic cycle, all right? So muscle spasticity. So when the joint gets locked down, you lose that proper healthy motion that keeps joints healthy. Say this with me. If it's not moving, it's dying. If it's not moving, it's dying. So that's true for joints, okay? So why do joints get arthritic? When I say arthritic, I mean specifically the common degenerative arthritis like osteoarthritis. Not normal, not natural, but common arthritic patterns, which are called osteoarthritis or DJD, degenerative joint disease, or OA, osteoarthritis. These result from lack of proper movement in a joint. So when a joint is designed to move, like a muscle is designed to move and a brain's designed to be used, right? If you don't use it, you lose it. If you don't use it, you lose it. When a joint doesn't move properly, effusion, swelling, pressure builds up, periosteum starts to break down, the bone tissue starts breaking down, the soft tissue starts breaking down, and you go through arthritic changes. Movement is life. Who believes that? Who knows that innately? Movement is life. When you stop moving, you start dying, okay? And it's true for joints on a micro level, and it's true for you on a macro level, right? Ask people that are 90 years old and doing great. What do they all have in common? I wish I could say that they've been at a regular chiropractic care throughout their whole life, because you know I would. I would tell you if that was the truth, all right? But all the ones that I take care of, the ones that I know who are my favorites, they have one thing in common. Two things. They have a great attitude, and they always move. And I don't mean they're busy. I mean they're active. Is there a difference? Mm-hmm. Yes, there is. Okay, lost inhibition. When the joint stops moving, it starts dying, it starts drying out, it dehydrates, so you don't get nutrients and toxins build up, okay? So you start rotting, okay? So you lose imbibition. Joint fixation and degeneration ensues, so that's arthritis, okay? So I use this term arthritis a lot tonight because it drives me nuts when people come after 2 or 3 years under regular care and I've been telling them about the degeneration pattern that's obvious on their x-ray, and I'm concerned because you're phase 2 subluxation degeneration, you've got these osteophytes and syndesmophytes and bone spurs and joint space loss, and they come back 3 years after and go, my medical doctor just told me I'm arthritic. And I'm like, I've been telling you that for 3 years. So I'm actually going to use the term. It's arthritis. That's what arthritis is. It's DJD, degenerative joint disease, okay? Which is what happens when a joint doesn't move properly. Okay, so how do you know if you have subluxation? When we check spines for subluxation, we look at it from 5 criteria, okay? So we use an instrumentation which helps us find inflammation, okay? So instrumentation, we use motion palpation to see if all the joints are moving properly, because in a healthy body, joints should move through their normal ranges of motion. Makes sense, right? And if there's any swelling or soft tissue damage or aberrant biomechanics, you can feel it with your hands. We also use static palpation. We use our hands to find inflammation in the spine and the joints, and it's really easy. If I had you close your eyes and handed you an apple with a bruise on it, I'd say find the bruise. You'd find it and be like, yeah, it's right there. That's what we feel when we feel spines. We feel edema from the soft tissue damage. Static palpation, visualization we'll talk about in a minute, and x-ray. An x-ray allows us to take a look at really what's going on the inside, because not to see is to guess, and we won't guess with your health. So we take pictures so we know exactly what's going on with things biomechanically, but we find it on the patient first, okay? Visualization is a really simple and powerful way to assess somebody. Chris, can I have you as a volunteer? Sure. Everybody say, nice job, Chris. Come on, everybody. All right, so I'm going to do a quick posture check with Chris. Chris, if you could, just face the screen for me. So does it make sense to everybody that a healthy body should be balanced? Okay, without a bigger, deeper explanation. Imagine ears over shoulders, shoulders over pelvis, pelvis over the hip, over the floor, right? So we should have a nice, even, balanced posture. Balanced is normal, and healthy is normal. Being unhealthy is abnormal. Say yes if you believe that, okay? So we've kind of gotten lulled into believing that being unhealthy is actually the norm or is normal. It may be common and be the norm, but it's not normal, okay? Healthy is normal. So in a normal, healthy posture, what we should see, stand relaxed for me, is imagine a line across the ears, across the shoulders, and across the hips. All right, this is a healthy specimen, so it might not be as easy for you guys to see this. All right, so imagine if you looked across the ears, which ear is higher, right one or left one? Can you guys see? Mike, help me out there. You get the best view. Which ear is higher, right or left?
Right, it's higher.
Dr. Tyler, can you see from back there? Okay. What do you think, Mike? Left. Everybody agree, left? Left is higher than the right? Look at the lobes. Okay, how about shoulders, right versus left? This one's easy. I can see it from the side. Okay, and how about the hips? This is a little tougher. Yeah, buddy. Okay, ladies, which one's higher, right one or left one? That's right. She was right on it. See that? All right, so when we see this, what happens is we can assess mechanical changes in the spine because if the body senses nerve irritation, it'll actually just lean away from it. Okay? Functionally, what it's trying to do is open up the joint so the nerve can breathe. Okay? But it creates two things that we can measure: postural deviations away from normal and a difference in how you carry your weight. Make sense? Okay? So when we look at this with Chris, the tendency, what I'm seeing with him is his whole body is basically listed off to the left-hand side away from the right SI joint. Okay? Typically when you see this presentation, left, 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 it's typically down below. If he was right, right, and then left up top here, I'd think compensation. Okay? But left, 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 I'm thinking SI joint here. Just on a quick pass, all right? So what my trained eye sees is a prominence here on the right-hand side, so his right glute is more prominent than his left, all right? Flat left glute, prominent right glute. What happens here is the SI joints, the way they subluxate is they rotate. They go internal or external, okay? So what I see on him is an internally rotated ilium on the left-hand side and an externally rotated ilium relative on the right-hand side, okay? Now what that's going to do is it's going to open up this SI joint and create problems in that right SI joint. Okay? I'd have to put together the rest of the puzzle using our other 5 criteria, but that's what I see. Now these nerves, if you remember, feed the muscles of the low back, bowels, bladder, prostate, reproductive organs down the legs into the feet. Now I also notice when he stands that he's got a left outward foot flare. Okay, so remember, if that femur head inserts up here into the hip and that ilium goes internally, rotates internally, what's going to happen is he's going to toe out on that side. Okay? So as he toes out on that side, think about how that's going to change his gait pattern. All right? Mike, you know about this with horses, right? So when that ilium changes and his feet are supposed to go like this and his gait's supposed to go like this, okay, so all the stress would translate knee over toe and go out that way. What happens if you toe out? You toe out this way, heel strike, what happens to that knee? Now we're doing this. And you see that crisscross? Imagine the stress on the inside of that knee. So now what do you think people walk in here with? Oh, I've got a problem with my left knee. They tell me I've got a meniscus problem in my knee or my medial collateral ligament on the left-hand side is a problem, right? And it's because their whole gait is screwed up. They're toeing out on that side, heel striking, and now instead of distributing forces evenly over that knee and foot, they're stressing the inside of that knee. And eventually, which knee is going to go under stress or trauma? That left knee is going to blow wide open on them, okay? Thank you, Chris. Interesting, huh? Just a quick scan so you can take a look at somebody's body and it'll tell you about their biomechanics, all right? So you can see where that would lead right in from hip problems into knee problems. All right, so this is where when we're talking about the actual hip itself, this is where we see this degeneration. When that SI joint's not working properly or the fifth lumbar is not working properly and the hip itself ends up carrying more stress, the hip breaks down and we end up with these issues here, hip replacements. Now, why do you think it's so much more common for women to have hip replacements than men?
Hips are wider.
Hips are wider.
I mean, you know.
Not some of the men I've seen now lately. All right.
I mean, the bone structure,
Do you think God screwed up when he designed you?
that was for babies.
Yeah, it was for babies. So you're on the right path. This is one thing that women do more commonly than men is that have babies, right? So, you know, when you look at, you know, the way the body is designed with the birth canal, with the anatomy and functionality of this, is around the world, and traditionally women would squat to deliver a child. Think about it. It opens up the birth canal, and you have gravity assist, and you lean against someone or something, and you use gravity to assist in the delivery. okay? And what have we decided to do in our brilliance in modern healthcare? Lie them on the backs, puts their knees up, right? So what are we doing to that pelvic bowl? What are we doing to that birth canal? And what are we doing with gravity, right? And we see, now 36% of the births last year in this country were C-section. All right, so we don't need to get into that conversation, but know that just the stress of the delivery in an unnatural way like that puts so much stress on those SI joints. You talk to moms, and they will tell you, nobody really warned you about the aftermath of having a baby, right? So how many felt like a train wreck after having a baby? I can remember, Camilla after the birth of Sam. Sam's delivery was like a bar fight. I mean, she was unbelievable, and there's like 18 hours. She did it all natural, but it was a stressful delivery. I can remember how banged up she was, and she's a tiny little gal, and he wasn't a tiny baby. And she had SI joint problems after that we had to put her back together. But imagine how many women are out there delivering children in a sort of unnatural way very commonly. Camilla's was very natural, and they get SI joint problems and nobody puts them back together. Okay, so they end up much more commonly with hip problems. And at the end of the day, a lot of people, by the time they get to us, their hips are so far gone, so far degenerated, that they have to have hip replacement surgery. We have worked with a great deal of people and helped them put off the surgery and even prevent some surgeries and help them be more comfortable through the whole process. But the give and take on this, as far as I'm concerned, is if they can have the hip replacement done once it's bad enough where they need it, I would rather have them do that so they can get back to life and become active again. Because I think the benefits of movement and activity far outweigh the risks associated with going forward with the hip replacement. That being said, I'm a champion of prevention. And I think that all the greatest orthopedics in the world should come together and say, is there any way we could go upstream and prevent some of this degeneration, because we see the business that this is turning into with replacing body parts, right? So hips, knees, shoulders, elbows, etc., right? So why don't we look at that and say, well, how come all these parts are breaking down? And why don't we go upstream and correct those problems early on and prevent the degeneration that leads to the need for a replacement? Okay, so what you'll very often hear is, whether it's a hip or it's a knee issue, what you'll end up hearing is, well, you've got a bad old knee, right? And that's part of the aging process, and you're just going to have to be okay with it. Anybody ever says anything like that to you, just kick them in the shin, right? What I like to do is I say, okay, so she has a bad old knee. Is that why she needs a knee replacement? That's why her knee went bad? Let me ask you, how much older is that right knee than the left knee? How many more steps did the right knee take than the left knee, right? Think about that. So why is it one knee broke down and the other one did? It's mechanics. There's a mechanical issue there, all right? So if we can recognize that we catch these things early on and go upstream, meaning go back in time and correct them when the people are younger, so that they don't ending up at the bottom of the hill with all these degeneration issues. Say yes if you believe that's a better methodology. And I think with the amount of money that we invest in modern healthcare and the resources that we have available to us, okay, in America, we should do a lot better than what we're doing right now, okay? Recognizing that there are some people that need surgery now and need help because it's too late for them and the joint is worn out. Let's learn from that generation and say, okay, what can we do for the 30-year-olds? What can we do for the 20-year-olds, okay? Because you can actually correct the problems with the pelvis, correct the gait, take the stress and strain off the hips and knees, and prevent these types of issues, okay? Make sense? Good? Okay, so let's talk about some of the self-care approaches you have to addressing some of these issues if you have some of these hip and knee issues. So one thing I wanted to teach you is foam rolling. So has anybody ever done a foam rolling consultation with in the office? All right, so this is available to you, okay? This is something that also I believe that these guys will be teaching in their CrossFit gym as well, all right? So the benefits of foam rolling are essentially it's having an intense soft tissue massage therapist doing soft tissue work on breaking down some of the fibrous restrictions and limitations in joint movement caused by aberrant biomechanics in your tissues. All right, so if you take a look at your leg and look at your knee, understanding the way the knee functions, you have a patella that acts, let me see if I have a good picture of it. So here's your patella right here, okay, which is your kneecap. Everybody reach down and grab your kneecap, okay? Feel how you can move it around. Feel how it like floats right up in there, okay? Here's a side view of your kneecap, all right? So your quads, which is the big muscle up on the top of your leg, the quadriceps, there's 4 heads, okay? They come down around your leg, okay? These are big movers, and the tendons attach into that patella, that floats, that kneecap. It's for attachment here. You can see that it's just floating across this femur as you go into a flexion position like this, all right? All those quads, the tendons insert on that patella, all right? And that patella moves in a track across the knee to protect that knee joint and to provide attachment. Make sense? Now, if the tone of that, of each of the heads of each of the, picture them like you've peeled a chicken apart before, right? Those are all different muscles, right? The meat that you see on the chicken. Your quads, you can do the same thing. You can pull the 4 of them apart. I know this, I've done it in lab, all right? So you can imagine there's a tone to each one of those 4 muscles, yes? And they attach to that sort of oval bone that sits in the knee. And when they attach to that knee, and as a leg flexes and extends, that patella moves up and down. Well, the tone of that muscle should be even across in a natural, healthy thigh. Make sense? If there's a problem with one of those muscles, or the scar tissues in one of the muscles, and one of those gets tight, what happens is it changes the rotation or the tracking of that patella. Make sense? So if you have let's say the outside of your leg is really tight, and the outside head, the vastus lateralis, this big muscle on the outside of your leg. Or maybe you have an IT band, the iliotibial band that runs down the side of the leg, if that's tight, all right? Where you have attachment to the patella, what you'll see is as you go through your natural gait patterns and movement patterns, the patella actually gets pulled off of its track, okay? So up underneath the patella, you end up with effusion, swelling, pressure building up there, and you get degeneration and breakdown. All right, so a lot of people come in here with these kneecap problems where they're like, it feels like it's like right underneath my kneecap, okay? Or right on the inside of my kneecap. Foam rolling makes a big difference there because you can actually roll out those tissues and correct some of the tone of the tissues themselves and break down some of the scar tissues. I don't know if you guys can actually see this, so I'm not going to put anybody down on the floor. But essentially, you know, you use this tube. Actually, Derek, can you just demonstrate for me? Let's just roll out a quad. So if you guys want to stand up, you can see this. Why don't we just do like your right quad? I think they'll be able to see you do that. Yep. So we're going to go from origin to insertion. So the origin of the muscle to the insertion. And if any of you guys want to learn to do certain joints or certain muscle bodies, you can make an appointment with us when you come into the office, and we'll take you out back and teach you how to do it. But essentially what he's going to do, he's going to flex right at the origin, and then he's going to relax deeply, and then he's going to move towards the insertion, and he's going to go basically in 4 to 6 inch spaces. So you'll work up the top 6 inches, flex that muscle, then relax and go deep on it, okay? And then you can actually pick your heel up and put some more weight down on that thing, and then shift headward. So you work towards the insertion. So there's 4 heads, so what you would do is essentially use that trigger point or that pressure point where there's contact being made into that muscle belly, contract the muscle, count for about 10 seconds, and then relax. And how long it takes you, it might take 30 seconds, it might take a minute to really relax and let that thing get right on there. And what you do is you kind of fish around for really tight sore spots. Once you find those tight sore spots and it becomes really, really painful, those are the ones you want to work on, okay? This is not a jacuzzi experience, all right? So you want to find those tight spots and really work on them and roll them out. And what you'll find is you've got common spots. You'll be able to find those points. Now you can do this to pretty much every body part, all right? So he could roll out the front, turn on his side, roll out the IT band, go down to his calves, roll out the back of the calves, turn over, run out, roll out the front of the tibialis anterior. And this is just a great part of your warm up and your cool down. Thanks so much, brother. Excellent. Give Derek a hand. Okay, exercise. So, Dr. Mark, you available? So there's one exercise that I think is just the absolute mac daddy when it comes to any low spine, hip problems, or knee problems, and that is the squat, okay? So we're all natural squatters, okay? So if you want to make this argument, I challenge you to go take a poop in the woods and tell me you can do that without squatting, all right? So this is how we're designed. We're supposed to go to the bathroom that way. We're supposed to eat that way, all right? Our bodies like to sit down into a full squat. The problem is we've screwed that up because a child, you watch any child, they can go and they can just go into a full squat and they're happy to play like that, and they go down and pick things up and they have perfect form. What you'll notice is he's got a tall chest, his knees are tracking over the toes with his knees apart, His feet are shoulder width apart, flat on the floor, weight on the heels. His hips drop below his knees. Back is straight and solid in extension, and his head is tactical, okay? So that's how a child will squat. This is how you should have grown up squatting, but unfortunately, you see those things you're sitting on, those evil things called chairs? Chairs, because we get raised sitting in chairs all our lives, it screws up our ability to squat, okay? So we all have this weak core issue, and we end up with contracture in our hip flexors and shortened hamstrings and the whole deal. So Dr. Mark, could you just demonstrate what a proper squat looks like? So he's going to go from the bottom up. You want to be flat-footed, weights on your heels, so towards the back of your arch, the front of your heel, okay? Flat-footed. First thing that's going to happen is going to drive his hips back and down, so butt back and down. He's going to keep a tall chest. He's going to put his hands up as a counterbalance. His eyes stay tactical. And he pulls himself down to the point where his hips are lower than his knees. He's pushing his knees apart. He's ripping the carpet apart with his feet. And then he's driving his feet apart as he comes back up into a stand. Good. So give me 3 in a row if you could. Pulling down and back, nice and low. And he drives back up. Pick it up a little bit. And now 1 at natural speed. Straight through. Excellent. Give him a hand. Okay, so that's squatting. That's the Mac Daddy. So if you say to me, oh, I can't do it because my knees are so bad. Well, what we would do is we would put you as a 0 level squatter, okay, and we would work your way up. 0, 1, 2, 3, 4, 5, 6. Okay, so there's a whole series of squatting progressions that we'll teach you. And believe it or not, getting those knees moving through those big ranges of motion will make the biggest difference and really help you. All right, so here's the man. This is K-Star, Kelly Starrett. He is demonstrating, here's a poor squat. You see the knees folding in, feet rolling, head dropping down, rolling out his low back. Okay, here's the right squat. Okay, so you can see knees apart, flat-footed. Okay, nice flat-footed and strong, weights on his heels. Tall chest, eyes tactical, hands out. Okay, if you want to read a good book, read his new book, How to Become a Supple Leopard. It's a great one. All right, you can actually learn a lot from him on his website, Mobility WOD, which is a great website, and it's featured on Bonfire Health as well. All right, so foam rolling, exercise, and cryotherapy. Ice is your friend, yes? So whenever a joint hurts or is swollen, put ice on it, okay? You want to ice that joint down for about 20 minutes. So 20 minutes on, 20 minutes off is a good rule of thumb, all right? When it comes to the knees or the hips, really get it cold, all right? So pack that thing, all right? Really get that deep, deep, deep tissue, all right? 20 minutes on, 20 minutes off. Professional care. All right, so these are people that you can utilize to help with some of these issues. Chiropractic, ART, which is active release technique, massage therapists, physical therapists, and MDs. All right, so let's talk a little bit about what each one of these do. MDs, they're brilliant at addressing certain issues, acute knee issues. You blow out your meniscus, you blow your ACL, you're a surgical issue. I'm not a big fan of these procedures where you're either making injections, because obviously, again, we're just treating the symptomatology, reducing some of the pressure so everybody feels better, but the joint just continues to break down, all right? Or doing clean out surgeries. I don't see those as being successful. I think once a person gets bad enough and they need a total replacement, I think that those are effective, and that's the way to go when it comes to that point. If it's interfering with the quality of your life and you can't move, then it's time for a replacement. Okay, but popping pills and masking symptoms is not the path to health, and it's certainly not a long-term solution. Okay, physical therapists I think are great. When my dad blew out his knee, he needed a physical therapist to work with him to make sure he was doing really specific strengthening exercises from an acute stage all the way through to recovery and rehabilitation. So that's fantastic stuff. Massage therapy is a great complement to all of this work, because you're going to have soft tissue, chronically spastic soft tissue around these unstable joints. So massage therapy helps break that down and restore healthy movement and motion and blood flow and lymphatic flows, etc. I love ART work, okay, active release technique. I get ART work done on me regularly. This is just working with some of the soft tissue issues that I've built up over the years as a chiropractor, adjusting all you wonderful people, and surfer and CrossFitter, and doing all the crazy stuff that I've done my whole life. So I've got lots of old scar tissue issues that need work, and it's just part of my wellness regimen. Okay, and then of course chiropractic care. So as chiropractors, we address things in 3 stages. All right, so there's a 3-legged stool of healing. So number 1, it's chiropractic adjustments done in rhythm. A chiropractic adjustment is a very specific force to correct the function and position of a vertebrae that's out of a healthy position, okay? The objective there is to stabilize the joint, stop the damage so the swelling goes down and the nerve starts to breathe properly. Remember, it's the nerve that heals the tissue, Okay, there's an intelligence that travels across your nervous system that keeps you healthy and heals your body. Our job is to make sure that there's no inflammation that creates nerve irritation and changes that information. Make sense? So adjustments done in rhythm. We do regular chiropractic care. Breaking the bad habits that cause your problems in the first place. If you keep crossing your legs or sleeping in a big twist or picking up things that way, you're going to keep causing the problem to reoccur. So our job is not to just shovel sand into the ocean, but actually to make progress, okay? And then exercise to strengthen, we talked about that already. So the specific exercises that we give each patient based on their injuries, weaknesses, or degeneration that will help them strengthen their intrinsic muscles of their spine as part of their rehabilitation so that they can hold their adjustments better. The longer you hold your adjustments, the better you're healing, okay? Next time, next month, shoulders, elbows, wrists, oh my. All right, so we're going to do part 2. If you know anybody that's struggling with upper extremity issues, we would love to have you back and bring them with you. Thank you, guys. Questions? You can ask me anything.
This is personal to me, that hip replacement.
39 minutes. Sorry, guys.
You said there that squatting is something we should be doing,
Yes.
and I was told squatting is something I shouldn't be doing.
Yes.
Um,
Who do you believe?
Well,
Yeah.
I take all doctors with a grain of salt, but
Right.
I've been trying to
Good
do
idea.
the right thing.
Yeah.
My daughter was a good pitcher, and I spent 20 years squatting. I was
Right.
better squatting at 40 than I was at 20.
Right.
Because I'm catching her. She's not pitching anymore. I'm not squatting anymore because that's what the ortho said.
Right. So if it's not moving, it's dying. Okay?
I'm still moving, but should I be
I
squatting?
do, but we need to take that. We need to take your body through a full range of motion. There are no limitations in the range of motion on that prosthetic joint. Okay, so you can go right through that range of motion. That thing is designed for you to go into a full squat. Okay, so what happens to that other hip if you don't take that body through its full range of motion? You'll end up you'll be getting a 2-for-1 deal, right? So you'll have the other hip replaced.
That's what I
Okay.
should be doing.
Yes, but we have to teach you how to do it properly. So improper squatting, bad idea. Proper squatting, good idea. So let us coach you and show you how to do it properly.
The squatting I know is catcher.
We will show you.
Okay? I'll see
So
you next Tuesday.
perfect. So if you watch a good catcher, because I'm also a baseball coach. So when you watch a good catcher, you watch them get up and down, up and up and up and down. They all have beautiful squats, or they never last, right? You watch them, that butt goes right back. You watch a catcher, and you'll see them up and down. They're just perfect, beautiful squatters. They have to be, because most of them are big guys too, right? Good natural squatters.
What's a club foot?
What's a club foot? Well, I see lots of club feet in here. Well, I mean, there's pathological club feet, which is a deformed extremity. But most of the club feet that I see in here are due to the fact that you women pack your feet into these really attractive, beautiful shoes for the first 45 years of your life, and then you spend the next 45 years of your life regretting them. Yeah, because we see, if you look at the way the foot is designed to be it's a perfect structure to distribute forces, okay? So if you understand the physics involved in a gait, there's a tremendous amount of force coming down on that foot. So the force is designed to spread right through the foot, right? It's beautiful. And if you think about how we're designed, God never meant for us to shove our feet in shoes and walk on cement slabs, right? We're supposed to be walking on grass and dirt roads and cobblestones along riverbeds chasing down our lunch, right? And the foot, if you look at a modern hunter-gatherer tribe, their feet look like hands, right? They can just grab, You look at your feet, they're totally deconditioned, right? Because you're stuffed in a shoe your whole life, always walking around on a flat surface. I tell people to get out and get barefoot as much as possible. Everybody like Dr. Mark's shoes? It's not an ab for Vibram, but that's the big idea with these shoes, right? Yeah, so this is the big idea. I'm like Sarah and Chris, I'm in flip-flops all the time. When I get home, shoes are off. We're out in the yard, running in the grass. I'm on the beach all the time just to keep my feet healthy and conditioned. I want my feet to be like hands, okay? Most of the club feet that I see in here are just, the feet are so deconditioned that literally through what's called Wolff's Law, the stress on that foot, literally the bones start to change and you end up with bunions and hammer toes and you know, all these fractures and just really nasty looking feet. And of course they start shoving rods and pins and needles and plates in there, and it's just, you know, feet gone bad.
At 8 years old, I was in a terrible accident. To this day, I fell. My friend wanted to have hopscotch, and she said, "No, I want chalk." So I don't together.
Should I sit down?
Yeah. I rolled the chair, I put it in the corner, and I went up by my grandmother's chicken coop, and I went up on top, and I threw it down to her, coming back down. And it hit the broken glass.
Yes.
How, I'm getting chills, how I ever climbed out of that pit.
And you cut your feet in the problems?
No, I was cut here in the back.
Oh, in the back of a hamstring. Okay.
And how I did it, I don't know, but I came down. She went screaming when she saw the blood. My grandmother came out in Italian. She put a tourniquet with the, you know, did a napkin. My 2 uncles brought me to Lynn Hospital. I got stitched up. Then they wanted to put a club foot. My mother cried. My father.
You mean they
went
wanted to
home.
put a brace on your leg?
Something.
Yes, yeah.
And my father went on shortwave radio, heard about a Sister Kenny in Australia and what she did for her legs, and now I'm a walking miracle. How much my father did all that work on my
So they
leg.
want, everybody saw Ferris Bueller. I mean, not Ferris Bueller, but
I got a terrible.
what is life as a
scar.
box of chocolates? What's his
Forrest
name?
Gump.
Forrest Gump. When they put the brace on his legs, right, and he wasn't able to move and walk, and finally he broke out of those and he was running. Well, that's the end of the day. The story is movement is what's key. If your leg had been put in a brace, you would probably have intrinsic atrophy, you would have asymmetry in function, and you'd have bigger problems.
Cribbed and I kept climbing out. Anyway.
Somehow you survived, Nancy.
I survived. I don't care about the scar, but I don't have any awkward.
God is good.
Yeah.
God is good. And we're all glad that you made it. All right, anything else?
When you see a lot of patients that have like lower back pain, but the lower back pain is really not on the spine.
Right.
That's really chronic, you have it all the time. It's more like over here,
Yeah.
sometimes going into the front.
Yeah.
Is that a hip problem?
That's usually an SI joint problem. So SI joint problems, when somebody goes like this, it's usually, it's an SI joint problem. Hip problems, you usually feel them out in here, and sometimes you can feel it up and through here. Now, very often, there's an SI joint problem called an ASIN ilium, which is what I was diagnosing him with, just looking at his posture, which is an internally rotated ilium that goes anterior and superior. That can very often cause tension across the inguinal ligament, which is that line right at the bottom of your abdominal wall. Okay, so when the SI joint pulls backwards, it pulls on this where it ties into the pubic symphysis. So you end up with this tightness in here. You're like, what is that in there? And it feels like a chronic groin pull. And so that's usually an ASIN ilium, and it masks, or it's imitating a hip, an actual hip issue. Hip issues are usually, they don't vary, they don't go away, they're really gnawing, they're really deep, and they're just sit right up in there. Okay, one more.
I have several friends that suffer from sciatica nerve.
Yes.
And it literally stops them in their tracks, they can't even move. So is that the lower SI?
Yeah, that can be SI joint, but that's much more typically a lumbosacral problem, which is that fifth lumbar down the bottom. So unfortunately, sciatica is our bread and butter because, you know, I'm a Gonsa doctor, so I attract a lot of disc problems. So people have been told they have disc problems, disc herniations, disc prolapse, this sort of thing, and sciatica. We see a lot of that. So that's almost always a fifth lumbar subluxation. And we get great results with that. Did you have one more question?
Oh, okay. If your spine is straight and the tops of your hips are on,
Yes.
one leg's off a little,
Yes.
do you ever recommend an insert?
That's a great question. So, you know, people get inserts put in all the time. Her question was, is if your spine is straight, but the hips are off, they're saying that you've got an anatomical deficiency in your leg length, okay? So the solution would be to put a wedge up underneath your foot, an insert, so it would help level out your pelvis, okay? So what I can tell you is it's fairly rare that a true anatomical leg length is actually playing into the role of the etiology of a person's problem, okay? But we do have a whole set of criteria that would probably bore you
whether a person's a candidate for a hip insert, a shoe insert or not. That's how we call it, a heel lift, okay? They have to be between the ages of 18 and 36. They have to not have an acute knee problem or hip problem, right? So there's a whole set of scoliotic curvature criteria, et cetera, that usually rule most people out, okay? Are there situations where we do use a heel lift? Yes, in very specific cases, for sure. But otherwise, typically when you take an x-ray of somebody and you see their pelvis is off like this, it's not because the one leg is longer than the other, although there may be a little asymmetry. The pelvis is usually rotated, so it changes the trajectory of the femur towards the ground. So the image on the x-ray looks like this. So you fix their SI joint, fix their pelvis, and next thing you know, they level out and their spine levels out. So we do a lot of that work. That's kind of our expertise there.
You did that for a 5-year-old, Jaden.
Yes. Her granddaughter. Excellent. All right, guys. Hope you got a lot out of this tonight. Thank you so much.